Good afternoon, please take a seat. I'm Dr. Jane Smith. I can see you're here today for a consultation. Based on your notes from the GP, I can see you've been suffering from a persistent headache and bursts of nausea.
Yes, I've been feeling like this for at least the last week or so, but I have been experiencing headaches for at least the past couple of months. These headaches have been getting worse over time, and lately I cannot even finish my meal before I start to feel nauseous and vomit. Also recently, I've started losing my balance when I walk, and sometimes I find it hard to talk properly. I'm really quite worried and don't know what to do.
I understand you're worried about your symptoms. However, you're in good hands and we'll figure out the best treatment options for you. Based on your symptoms and your CT scan, I think it would be a good idea to do further tests. I would like to do an MRI as well as a biopsy to help us have a better idea on what's going on.
Okay, if you think that's the best.
Good afternoon, Mr. Robertson. Thank you for coming in today. Please take a seat. I've had a look at your test results and I have some bad news. We're fairly certain that you're suffering from a glioblastoma, which is a form of malignant brain tumor.
What does that mean?
Unfortunately, your prognosis is poor, even with treatment. However, there are treatments that could help extend your life expectancy. Would you like some more details on this?
No, thank you. I think for now I'd like to focus on what my treatment options are.
Normally, the treatment that I would recommend is a combination of radiation therapy and chemotherapy. However, there currently is a clinical trial using immunotherapy that you would be eligible for, which has some promising results.
How does the immunotherapy option work?
Smith and Mr. Robinson are discussing their treatment options. Let's take a look on what glioblastoma is all about first.
Glioblastomas, derived from glial cells, are a specific type of aggressive malignant brain tumor that commonly occurs within the central nervous system. Malignant transformational gliomas occur as a result of sequential accumulation of genetic alterations and abnormal regulations of growth factor signaling pathways. This includes molecules like the epidermal growth factor, hepatocyte growth factor, vascular endothelial growth factor, and platelet-derived growth factor. According to experimental data, it is possible that glioblastoma within adults may originate through genetic alterations that impact the neuroglial stem or progenitor cells, which are located within the subventricular zone, the subcortical white matter, and the dentate gyrus of the hippocampus. Currently, the underlying mechanisms behind glioblastoma growth and invasion are not completely understood, since most studies focus more on animal models and data from humans are generally based on the result of autopsies. Patients with glioblastomas present different signs and symptoms due to three mechanisms. The first is by direct effect, in which the brain tissue is destroyed due to necrosis, leading to symptoms that include focal neurodeficits and cognitive impairment. The next mechanism is by secondary effect, where increased intracranial pressure as a direct result of gradual increase in tumor size and increased edema surrounding the tumor leads to a shift in intracranial contents, causing headaches. The last mechanism is dependent on tumor location, where patients are present with seizures, normally with a focal onset that may be simple partial, complex partial, or generalized seizures.
The current standard of care treatment includes radiation therapy, chemotherapy, and medications. However, they remain unable to improve the overall prognosis of patients. The median survival rate post-treatment is only 12 to 15 months. Therefore, immunotherapy, an area of research that might have promising results, is further investigated. Approaches to immunotherapy with LAK cells as an adjuvant therapy has been seen with various types of cancer of varying malignancies. In a study by Dillman et al., patients with recurrent GBM had autologous LAK as an adjuvant therapy. LAK was used intralesionally by directly injecting the substance into the lesion, which aims to deliver a high concentration of medicine into the site of the pathology to maximize efficacy while minimizing systemic adverse effects of the drug. LAK cells were produced by incubating autologous peripheral blood mononuclear cells with interleukin-2 for 3 to 7 days, which then was placed during craniotomy by a neurosurgeon. The treatment was well tolerated, aside from the effects commonly associated with a craniotomy. The median survival rate at 20.5 months is about 88% longer than the 12-month survival rate at the time the study was designed. In subset analyses, superior survival was observed for patients who received higher numbers of CD3+, or CD16+, or CD56+ TLAK cells in the cell products, which was associated with no use of corticosteroids in the month before leukapheresis. Large clinical trials would need to be conducted with LAK to improve efficacies of the treatment. In a study conducted by Vinick et al., they have discussed the current immunotherapy programs, its shortcomings, and the areas of improvement which can be done with additional research. In their findings, they discovered results of conducted randomized trials in immunotherapy in glioblastoma inevitably, and almost collectively, point to a lack of efficacy. These disappointing results may reflect the shortcomings of the current immunotherapy treatment strategies. Glioblastomas are very low immunogenic tumors located in a T-cell poor CNS compartment and embedded in a particular immunosuppressive microenvironment. We, therefore, recommend future treatment strategies that sensitize glioblastoma to immune therapies. Rationally designed combinatorial immunotherapy approaches offer tremendous opportunities to ultimately fulfill the high promises of immunotherapy in glioblastoma.
As we all know, gliomas are heterogeneous tumours, and the identification of the immunologically relevant antigens is challenging for us. Most of the tumour-specific mutations or neoantigens are unique to each individual. Gliomas are heterogeneous both among different patients we see and within each patient. These two forms of heterogeneity make targeted therapies, even immunologically based ones such as our vaccines and engineered T cells, more challenging for us to develop for our patient groups and for our individual patients. Even in early trials of CAR T cells, antigen escape has occurred in both hematologic and solid tumour malignancies. The identification of single targets is difficult, but the reality is that in the long run, multiple antigens will need to be targeted for most patients to have a reasonable expectation of clinical benefit. One of our principal challenges that we're facing right now in the development of new CARs is the identification of an appropriate cell surface antigen to target. The principal antigens that we have targeted with HLA-independent CARs include our human epidermal growth factor 2/NEU, our interleukin-13 RA2, and the epidermal growth factor receptor variant 3. We are, however, also interested in Ephrin A2 targeted CAR development, but these CARs have yet to enter our clinical trials. All in all, the core challenge of vaccine development for us is to find a protein that elicits such a response that is consistently expressed by tumours but not by healthy tissue in our patients.
Back at the doctor's office, Mr. Robinson decided to try immunotherapy.